in Bristol and founder of the Bristol charity A Breast. Zoe, good morning to you.
Hello, good morning, John.
I'm sure you're not surprised by the news from Cancer Research UK that they have seen a fourfold increase in the number of inquiries from women concerned that they might be carrying this faulty BRCA gene, BRCA1 or BRCA2. This is a difficult one, isn't it? Because it's once you know, it's what you do next, of course.
I think there are just 2 points, John. I think the population of women we're dealing with now are very much more informed, and obviously when you have a celebrity like Angelina Jolie, that raises one's information seeking and knowledge to the forefront. And I think it therefore becomes the responsibility of multiple clinicians in the area to balance that information very carefully. And those are quite difficult conversations, but it's possible to sort of deconstruct it and actually try to simplify. And so I'll try to do that just in this brief chat with you. It's firstly clearly not the majority of women with breast cancer. It would be 1 in 300 or 1 in 500 women that actually have a constellation of family members with either breast and or ovarian cancer or bilateral breast cancer. So we're talking about 10% or 15% of women. The majority of women do not inherit a gene that we actually test for. So that's the first point to make. However, those women that do have a clustering, as I've described, really should see their breast surgeon, who would then talk through with them a strategy for getting a risk adjustment. And that's done in a very kind of balanced, informative way. If that then comes up as a basis for referral to a geneticist, that is occurred once again, and the process of testing occurs, which can be, in some cases, shown to be negative, even although a higher clustering of relatives occurs.
Well, let's talk about that clustering for one moment, Zoe Winters, because there are familial links with a number of cancers, not just breast cancer.
Exactly.
But what would you call a familial link? Would you say that? Excuse me. Would you say that if your mother has breast cancer or has had breast cancer, and there is a history of breast cancer down the female line of your family, and you are the daughter, how many links would it be? One,
no,
two, three?
It's not as simple as that, John. It's 50% contribution from either the mother or the father. So it's not just restricted to the mother or the maternal side. It could also relate to paternal. So just to make it very simple, and I always refer back to a general chart on this, just to try to talk through that with women. We're talking about numbers of relatives. So as the numbers go up, that's important. Not just your mother having had cancer. That would increase it marginally twofold, but not to the levels that we're talking about in terms of genetic testing. Or we're talking about early age of onset, where the cutoffs are either under 35, under 45, under 50. Just a point about under 50, there is a recent sway where women diagnosed with breast cancer under 50 we should lower the threshold for considering doing risk scores on them. Now, that opens a big discussion, and we'll just shelve that for the moment, but I just bring that into the discussion.
So how many within that paternal or maternal family group would you then say, right, you need to be checked? 2, 3, 4?
It could be 4 family members, or it could be 2 members with early onset before 50 years of age.
Right.
And suddenly, just the earlier age of onset escalates that risk. Or a question of bilateral breast cancers could escalate. We mustn't forget that we keep talking about risk-reducing surgery for breast risk reduction. We must talk about risk-reducing surgery for ovarian cancer, because it is found that in these women, that not only is there an 84% predisposition to breast, there is up to a 63% predisposition if you carry the BRCA1 to ovarian. And also it has been shown that apart from risk-reducing breast surgery, that if you remove the ovaries and the fallopian tubes, you will also impact not only on diminishing ovarian and fallopian tube cancer, but you would also impact on reducing risk in the breast. And this is a very intriguing biological finding because it doesn't apply to non-BRCA cancers.
So, in very simple terms, Zoe Winters, is this about, if you identify within your genetic makeup that you are carrying this BRCA1 or BRCA2 gene, BRCA gene, that the only course of action to take if you want to avoid the very real possibility of getting either ovarian or breast cancer is to have your ovaries or your breasts removed?
Yes.
That is it. That's the only course of action.
No, it isn't the only course, John, but probably in the balance, it is the most interventional in terms of its effect, where the impact on that effect is much bigger. In other words, we're taking that high risk, which is 2/3 greater risk, and we're bringing that down to the risk of the normal population. Now, that's a big impact.
Okay.
Now, the other approaches could be early screening or could be drug risk reduction, but the drug risk reduction will only take it perhaps to half of that, not to the lower levels of the normal population.
Okay, so we stay on the line because I'm going to bring in Lorna in Ashley Down. Lorna, good morning.
Good morning.
Welcome to the programme.
Thank you.
You had breast cancer.
I did, yes.
And it's all clear now?
It is, yes.
How did you find out?
I found out because I had a small lump on my breast, and I went to the doctor, and they sent me straight to the breast screening clinic in the BRI. And basically, it's a one-stop shop, so they look at you, they give you a scan, they gave me the mastectomy, and the decision, they will give you that decision there and then.
Right,
so
from breast lump, from identifying the lump
yes.
to treatment,
yes.
How quick was that?
Very, very quick, actually. I think I was in, and I had my mastectomy within, I think, a month, if not less, actually.
So almost no time to think, really, just to get on with it.
I think in my case, when you know that there's something wrong, I just wanted it out of my body. And in hindsight, I wish I'd sort of researched it a bit more, because I did have complications.
Right.
But at the end of the day, I feel as though it's been taken away. It was caught very early, and I feel I've been looked after so well, and I had to trust the decision of the consultants and the surgeons, because I had to,
So this is obviously, I want to say a common scenario, Zoe Winters, but it isn't, because every breast cancer journey is different. Yeah. But Lorna there being, and we're very short of time because I need to go to the travel in less than a minute. Lorna, from lump to mastectomy was a month. That's a very brief time to get your head around something like that.
Quite right. I mean, hi Lorna. I mean, that's very, very different to what we're talking about in some ways, because we're talking about women who don't yet have a cancer and we're trying to prevent it. Now, it's likely that Lorna fits into the majority of women which don't have this particular gene, but Lorna, understandably, we know that window of a month is quite a short time, but we have tremendous targets. I'm not saying they're all logical in personal or medical terms, and I do agree when you're making difficult, late surgical decisions like mastectomy, I always say to my patients, please absolutely bed in with the information. Don't knee-jerk on any decision. Interrogate your surgeons. Make sure you find out their individual complication rates. Make sure you understand the impact.
Zoe and Lorna, can you hang on? I need to go to the travel, otherwise I'm going to get told off by the management. But can I ask you just to hang on, because I want to explore a couple more issues with you. Is that okay?
Yes, of course.
Thank you very much.
Thank you.
Well, let's return to what we were talking about, or what we started with at 9 o'clock this morning, nature versus nurture, medical science being able to identify issues, medical problems that may exist within you and offer you solutions, thus bucking nature, knowing that you could change your genetic makeup or react accordingly to it. Cancer Research UK say that there has been a fourfold increase in women trying to ascertain whether they are likely to be carrying the defective BRCA gene, which would lead to ovarian and breast cancer. Angelina Jolie is the reason for this, because she had a double mastectomy last year as a result of having that particular gene. Well, still with me is Zoe Winters, breast cancer surgeon based in Bristol and founder of the Bristol charity of Breast. Also Lorna in Ashley Down, who had breast cancer and had a mastectomy. Lorna, I would like to start, if I may, back with you. Mm-hmm. The moment you were told that you would have to have a mastectomy, what was the first thing that went through your mind?
Obviously, it's devastating, because it's it's
but
part
why?
of the body.
Why is it devastating? Because you're being told you've got breast cancer that will kill you.
Well, not necessarily will
Right.
kill you. Basically, you're being told you have cancer. And at the time, I didn't realise that. I thought it would just be a lump taken away. I didn't realise the whole thing was going to go.
Following on from what you said before the travel, which is, I want that thing taken out.
Yeah, basically. But I didn't put two and two together. And as Zoe was saying, I really wish that I had challenged my surgeon, because the reason that I've had so much surgery ongoing is because I went for a solution that actually wasn't good for my body, and that's why it went wrong. So I really wished I challenged them, because there are different options out there. There are different surgeons that have different ideas, and there are people there that can help you and advise you. But because I was in such a stress, all I wanted to do was get rid, and I had to listen to that person.
And I would imagine, Zoe, that the expedience of a diagnosis from the point of view not only the medical practitioner but also the patient is, if someone's told that they've got breast cancer or testicular cancer or ovarian cancer or whatever it may be, is, I want it out, and I want it out this afternoon.
I know, and that is such a human response, John and Lorna. And you know, as a physician, as a doctor, I would probably have that gut reaction. But I think, you know, it is about really what we're saying, having good informed consent, understanding that different approaches to breast reconstruction can have different impacts on the body, and that we have to balance the physical and the emotional impacts against the cosmetic side of things. And I always discuss this, and we research it because we're very interested in how it impacts on how women feel from the perspective of all aspects of their quality of life. So we know that we can't divorce those things. It's not just about removing the breast, and also sometimes it can almost help to take reconstruction in two stages, where we can have a holding stage, sometimes if we're not sure about needing to add additional aggressive therapies that could affect the cosmetic appearance of the breast. So, you know, there's a much greater, I think, understanding and lowering of the threshold. And, you know, I think the patients have to feel empowered. And in that short window, that is about trying to come up with a clear solution where options are given, trying not to pressurize, and also trying to reassure women that primarily when we offer mastectomy and reconstruction, that we're primarily focused on treating the cancer.
Lorna, what would you have done differently?
Just at the very beginning, when I was given my choices, the surgeon, I think, had his favourite operation, and that was the one that was being advised for me to have. And just really myself not researching properly and talking to other people about it. I'm not saying the surgeon was, you know, bad or anything. He did a great job, but it was because it was wrong for me. I have had lots of complications.
So you're where you are now is clearly not where you wanted to be on a number of different levels. But Lorna, have you come to terms with where you are now? Yeah,
absolutely. Well, it's been nearly 4 years, and I had my last operation. And actually, it's quite funny having Zoe on the phone, because after things did go wrong, I'm under her care, and she's the person that's actually got me to where I am today by sending me to a plastic surgeon and keeping an eye on me through the process. So, you know, she sort of came in and helped me finalise the whole situation.
Lorna, I'm really grateful to you for joining me this morning. Thank you very much for being so candid. Zoe, I just want to ask you one last question, because this BRCA gene is the launch pad for what we're talking about here. And this is the ability now for medical science doctors to be able to identify defects in our genes that can give pointers towards things like Alzheimer's or Parkinson's or cancers various.
Yeah.
This is changing. This is changing the fact. This is almost godlike, isn't it? Insofar as we can look at a gene and say, well, I can take that bit out and I can make you better, or you can do this.
I think
where is the line? Where is the line?
I think godlike is not necessarily a bad thing. It's only a bad thing if you don't have evidence to back up what you do. So in our godlike approach, we're trying to be as conscientious in where the trial evidence takes us and what it's pointing us to. So we're trying to help women position the advances or position their information and their decision-making based on tremendous advances, which has to be in the round progress in the right direction, and actually reducing women's risk and actually reducing breast cancer and ovarian cancer events and subsequent mortality.
Let me put this particular point to you, and I put this to you as from a point of view of debate, not from any other reason. But if you are able to change the course of the BRCA gene by removing the breasts or the ovaries from a woman, thus negating her chances of contracting cancer, are you not effectively allowing that gene to continue being passed on down the line?
Well, I'm not a geneticist, and I'm not Richard Dawkins.
No.
BRCA.
I'm just saying that if you're saying that we can take the ovaries out, you can't remove the gene, but you can take the ovaries out, you can take the breast away, so thus stopping the instances of cancer. The gene is still there; that could still be passed down the line. That the gene would go with death, wouldn't it? Ultimately,
I hadn't sort of thought about it from that perspective, John. I guess what I would say is that principally we need to build on most of these studies are big sort of population studies, not necessarily randomized trials, which are obviously the best way to remove bias. But in big cohort studies, it is very compelling that this is not risk eliminating, this is risk reducing. We also need to bear in mind that when young women present with a breast cancer, perhaps women like Lorna, not necessarily Lorna, they may then subsequently discover they have the gene. And consequently, we are often in a context where the cancers can be more aggressive and where they are more life-threatening. However, I would say that there are very important evolving trials looking at particularly taking the BRCA as a target and using it with biological modifiers and chemotherapy to better treat the women that carry the BRCA.
Okay.
Whether you feel that we are impacting on the natural pool of the gene, I don't know that I can answer that. I'd have to think about
you
that.
Can see the point I'm making, because this, I mean, in very, very basic terms, this is Darwinian, isn't it? It is the principle of these defects would weed their way out by selection.
Yeah, I mean, I can see it's an interesting concept, and I think I need to do a little bit of thinking on this one. But I think what we're in, the realm we're in, John, is prevention rather than having to subsequently escalate treatment and have life-threatening effects.
Zoe Winters, great to talk to you from the Bristol-based breast cancer charity, Breast. Many thanks for your time on BBC Radio Bristol. Thank you.